Does it treat addiction? No. What Suboxone does, get dopamine to the brain, recovery of the receptors, and what's neat, remember that kappa we talked about? It turns it off like a switch on the radio. Click. It's just a subtle click. In 1 to 2 weeks, that patient comes back after doing a home induction. They come back, and when that person comes back, they say, God, Doc, I feel like I got my life back again. I say, Joe, how's your hip pain? Oh, Doc, I still got hip pain, but I can live with this. That's the difference. You convert it, I can't live with it, I'm going down the tubes. So, what do you put on the chart? This is the practical portion. We have 2 groups of patients. The patients, remember our addict over here, I pick on you again. The addict we'll put down as a substance use disorder, opioid use disorder. She goes on my federal list. Okay? The person who has been prescription only, am I going to put them on my federal list when I start Suboxone? Absolutely not. I'm going to put that down as this. It's going to say opioid dependence, uncomplicated. That gets you insurance approval because Suboxone is indicated for the opioid dependence. It's not indicated for addiction. Okay? And then I put pain management, Suboxone - off-label. And I do not put them on my federal because I am not so worried about you in the street and everything else. But what I'm doing is trying to correct the damage that I've done to your receptors over the years that you've been under my care. So that's the whole purpose. So I've got about 200-300 patients now that are on Suboxone for pain management, quote, pain management. What I'm really doing is cleaning up the mess, trying to get their receptors back. That's really what I'm doing, but we call it pain management. Okay? And what that does, it also, when the person, and we'll talk about this in a few moments, this fellow over here, he's been my patient for 5 years, or maybe your patient, maybe 10 years, and he's on a high-dose narcotic. He's followed everything we've asked him to do. I don't want him to walk out of here with a label. I want to walk out of here and say, I'm sorry. That's what we did to you. Now we're going to work on correcting it. We're going to help you. So what do you tell pain patients? They show up, and I was asked by someone over here earlier, how do you get them converted? How do you tell a patient that we're going to change you from a narcotic, a regular full agonist, to this weird stuff? And here are my 7 points. And I think this is important for pain patients because you have to respect, I think we have to respect where they come into the world and how they see the world. 1, we tell them it's not about addiction, it's about receptor loss. And what I do, well, why would I have the word show? Because people are visual learners. Most of us, you can show us a picture and we'll go, uh-huh. I can talk to you for 20 minutes and you'll go, you go home, you tell your wife says, what'd the doctor say? Yeah, I don't know, he talked for about 20 minutes. So what we do is we'll do a couple, we've got some standard pictures. Sometimes I just draw a picture of their head. Tell them, okay, Jill, this is you. Here's a place in here we're going to talk about. There's a place up here that makes a chemical called dopamine that goes into that, but I'm going to be cartoony a bit more, and I'm going to draw it out here and make it look like a big tall tower. And when I put you on a narcotic, this one floods more dopamine into this. So this floods a lot of dopamine into this receptor. The brain, recognizing that as too much, starts to shut off my receptors. And when it does, the patient will, if it's a female, I'll talk about old Joe. If it's a male, I'll talk about Barbara or Betty. I want them to know I'm not talking about them. It becomes an illustration because otherwise I want to depersonalize it. I don't want them pulling back and doing this stuff. So I said, when you get down here, when you knock off the receptors, many patients, old Joe says, you know, doc, those pills don't work. The doctor says, Joe, you're just getting tolerant to it. It's normal. It's medically acceptable. It's okay. Increase your dose. So he increases the dose, adds more narcotic, and we get another flood. Just like I said before, we knock off more receptors. When the receptors are knocked off, the patient says, gee, those pills don't work any good. They're not, my pain is coming back. I'm getting worse. Don't worry, Joe, increase your narcotic, so we increase it again, and the story keeps going. About this point, the patient, I watch them out of the corner of my eye, and they're going, yeah, that's my story. You can show it in different ways. You have to have your own cartoon. But you show the patient, and that way they'll remember something like this. They'll come home and draw some kind of picture of Joe for their wife or their husband. But they have the concept. So the first one is, and then the second thing we tell them is that when you get receptor loss, when this happens, we're going to get more pain. Oh yeah? And then I say, but we've got this new narcotic. I tell them it's a narcotic. It came from Europe. And this is an important thing. I tell them, listen, but this narcotic, this thing we got from Europe really isn't designed for you. It didn't come in this country for you. You're not even on the radar. This country was brought in for IV heroin addiction. And it wasn't for you. But here's what happened. It was brought in to treat heroin addiction and found out it worked for oxycodone, worked for morphine, it worked for everything. And meanwhile, as pain doctors were loading up narcotics on our patients. And we caught on finally. We said, well, gee, can we use this to treat what goes on in the brain for the narcotics that we give them? Because the brain doesn't care who gives it to them. And so what we did is we took this from the other doctors, and we're kind of using this in a different way, but it works like a charmer because it brings back receptors, and it's called Suboxone. And when you get home tonight, go ahead and look at it on the internet, and you're going to see it was really brought in for addiction. You tell them that, because if you don't, they're going to go home, they're going to look it up, and guess what happens? What are they going to do? That's right. Are you going to take that and fill that prescription? No way is right. So we tell them right on the front, this is going to happen. That's number 3. Number 4, we tell them that when you do this, your pain is going to be there, but you're going to have less pain. Boy, they don't expect that. Okay? And you may find that within a week or 1 to 2 weeks, your pain, all at once it becomes tolerable, and you kind of feel more normal. When that happens, when we put them on Suboxone and you see them on their recheck, we do a home induction, we see them 1 or 2 weeks later. When we see them that 1 or 2 weeks later, they've got a smile on their face. If they come with a spouse, the first person I look at is the spouse. If they're smiling, I'm going, yes, we nailed it. And they're happy. Did they get back receptors in 1 or 2 weeks? You guys are the scientists. Would they get back receptors in 1 or 2 weeks? That's exactly right. No problem. They won't. But we turn off their kappa in 1 or 2 weeks. So when you see that happening, and the patient says, God, I can live with this now. What you did is you turned off their kappa. And that's why it has remember, it's the only opioid that turns off kappa. All the rest of them increase kappa. Okay, number 6. I emphasize that we're going to get back to receptors and your pain is going to continue to improve because they just can't have this concept. And then we talk about tapering. And when we do, we're going to taper your dose down. Why? You're going to taper me down. You're going to get me off? I said, no, we only get about 20% off. Most of them, we get you down to a low dosage in 1 or 2 years, but we'll never get them off, and that's okay. I said, well, some people want to get off completely. And to them, I say, well, you want to get off completely. In 1 or 2 years, we'll get you down to a low amount, maybe 2 or 4 milligrams. If you want to get off, we'll tell you how to do it. We'll tell you the protocol. We're going to mention how to do that tonight, too, a little bit. It's in your writing. That part is more written than any other place on the notes we gave you. But what we'll do is we'll get them down, but it comes with a money-back guarantee. We take you off the Suboxone. We tell you how to get through it. We check them every month for probably the next 6 months or so. They're doing fine. We're done. Okay. Now, they all know that if I get exposed to opioid again, it could go up like a rocket. It's fast. So don't ever think cure means off means I can take narcotics like I did before. Wrong. Don't do that. So we talked to them about tapering because they've spent their whole life under medical care for pain management with increasing narcotics. And here comes some guy along, says, I'm going to put you on another narcotic, and I'm going to start decreasing your narcotics, and you're going to leave me in pain. That's what you're going to do to me. You're going to leave me in pain. So we have to explain that. It doesn't work that way. We only taper the dose when your receptors come back and take over. And so if we drop your dose and it's too great a drop or too fast, you won't have receptors back and you'll feel dysphoric and feel lousy. If that happens, it's my mistake. So then we ask the patient, what would they like to do? About this, at this point, around 80, 85% of them will say, sign me up. How do we get on Suboxone? The others will say, think about it. I said, well, go home, think about it. Come back if you ever think you need to have that. Well, doc, I really want to just have my 110 milligrams of morphine equivalents. I'd just rather have that. Well, I like to say, that's okay. What you need to do is you'll need to find a physician that prescribes it for you. I would certainly not do it for you. Why won't you? Well, there's two things. I could care about how you feel today, or I can care about how you feel in 10 years. The 10 years is what my goal is. I'm responsible for your health while you're in my care for long term, not just quick. And so I won't, and I'll say, but you can certainly look in the phone book and call some other doctors and find someone else who's willing to do it. That's it. Don't make it punitive. Don't get excited. Respect them to do that. And you'll get some phone calls about a month later, or they'll show up again. They'll say, well, I've thought about it. What they did is I said, did you check around? Yeah, I couldn't find anybody. That's okay. But I did it on their terms. It's important that we respect people.